Organized by AGIR, and we have four speakers this afternoon about the lesson that can be drawn by after the COVID crisis. So, Jean-Louis, if you want to
add thank you, Jean-Christian. I think it's really important to try to have some clear messages regarding what we have learned during the COVID-19 session, and we have really outstanding speakers in the different topics. And the first one is John Hertz from London. John, we are really honored by your venue in this Congress in Lyon, because you have published among the most interesting papers and most important papers in the field of reduction of exacerbations during COVID-19. So we are excited to see your presentation. Thank you very much.
So thank you for the kind introduction. It's very nice to be here in person in Lyon and to see you all here today. And I'm going to extend a warm welcome as well to everybody who's joining online. It's a pleasure to welcome you to Lyon virtually online. If I could have my slides, please. So by way of introduction, I'm John Hurst. I'm Professor of Respiratory Medicine at University College London. And over the next 15 or 20 minutes or so, I've been asked to outline the impact of COVID-19 on exacerbations of chronic respiratory disease. And we'll have a look at some data from asthma, from bronchiectasis, and from COPD. But I'd actually like to go further than that and actually try and draw out some positives. What can we learn from what we've seen in relation to exacerbations of respiratory disease? Before we start, a conflict of interest slide. I don't have anything specifically in relation to this presentation. I'm very grateful to AGIR for facilitating me being here today. So this is what we'd like to cover. So what happened to hospitalized respiratory exacerbations during the COVID pandemic? And why did that happen? And how can we leverage those changes to improve people's respiratory health in the future as we build back from the pandemic? And finally, to think about some other consequences of the pandemic on care for people with airways disease. So we'll start with my own area. My own area is COPD. And my clinical work takes place here. This is the Royal Free Hospital. It's in North London. And I guess like many people, when the pandemic started, we wanted to track what was happening to our regular admissions. And so this is a simple plot. You can see the year before the COVID first pandemic wave hit the UK, 2019-2020 in blue, and in orange, 2020 to 2021. These are the number of hospitalized COPD admissions that come through our door. These run financial year to financial year, so the April of 2021 was where we were really getting hit very hard in London. I take two things away from this. I take a reduction in hospitalized COPD exacerbations in every single month, but also that this is much flatter, that we're not seeing the winter peaks that you would normally expect to see with hospitalized exacerbations of COPD. Well, so much for local data. What else do we know? Well, perhaps one of the advantages of working in a large health service like the UK National Health Service is the ability to collate large data sets. And that's what this does. It's called an interactive health atlas. References at the bottom of the page. And this looked at 5 indicators of emergency hospital admissions. We're going to show you some data from 3 of them. We'll look at asthma, we'll look at COPD, but we're going to start with all respiratory admissions. These are based on coded diagnoses, and I should point out that COVID diagnoses are excluded from this. So we're not looking at COVID here, we're looking at all other respiratory disease admissions. So orientating you on the y-axis, we have the rate per 100,000 population, and we have years on the x-axis. This is all respiratory disease, and you can see in general that admissions for respiratory disease in the UK over the past 6 to 7 years have been slowly but relentlessly increasing. There was then a profound reduction in the year of the COVID pandemic, to around 44% of its previous level. The figure there represents, or the box plots represent, median, interquartile range, 5th and 95th percentile for very small units of the NHS, so they're called CCG, or clinical commissioning groups. And as well as there being a profound reduction in exacerbations, a profound reduction in admissions for all respiratory emergencies, notice that there's reduced variation as well between different parts of the NHS. So this wide variation that we normally see had disappeared. So that's all respiratory disease. Let's have a look at asthma next. It's a very similar picture, isn't it? Perhaps flat in terms of the long-term trend, but overall a reduction in asthma emergency admissions from about 100 per 100,000 per year to around 44 per 100,000 per year. And you can see reduced variation as well. The picture and the data, well, they're very similar for COPD, so let me show you something different. This is a map of England, and what we're looking at here on this heat map are the rates of admissions during the pandemic compared to the rates before. The cooler colours, they are reductions. The colder the colour, the greater reduction. But there were some areas that actually saw a relative increase in COPD exacerbations. And those are congregated in the industrial heartlands, or at least the former industrial heartlands of England: Liverpool, Manchester, Leeds, Yorkshire. And it's just possible, isn't it, that people with COPD in those more deprived parts of the UK were not able to shield, or were working and living in households with people who had to go out to work because they weren't doing financial jobs in the City of London, they were working in shops and factories. It's a reminder, isn't it, that COPD is a disease of inequalities, and also that COVID is a disease of inequalities too. So I've shown you some local and some national data. Can we go even wider? And the answer to that is yes. This was a systematic review conducted by Jabir Al-Qahtani, a PhD student within my group, who collated together and did a meta-analysis of the effect of the COVID pandemic on hospitalized COPD exacerbations. 9 studies included here. Notice that they're all in the same direction. Not a single study showed an increase. And the end result of that meta-analysis is a nice, round 50% reduction in hospitalized COPD exacerbations. We'll come back to why in just a second, but before I do that, we've got one more obstructive lung disease to look at, and that's bronchiectasis. As you might expect, there's much less data in bronchiectasis. But this is a nice paper from James Chalmers and group in Dundee. And it did 2 things. It asked a lot of patients with bronchiectasis about their day-to-day symptoms. In other words, was their disease control better or worse during the pandemic? And their disease control was about the same. Daily symptoms of cough and phlegm, they didn't change as a result of shielding. But what did change, even in bronchiectasis, a condition perhaps that we associate more with bacterial infection, was a reduction in exacerbations. So what James and team have done here is plot 3 years' worth of exacerbation data in the same patients, and they've split those patients into those who have 3 or more exacerbations per year, that's in the red bar, 2 in the pink, 1 in the blue, and the people who had no exacerbations are in the fluorescent green. Notice the increase in the proportion of people who had no exacerbations in the final pandemic year. So it's all pretty consistent, isn't it? A reduction in asthma exacerbations, reduction in COPD exacerbations, a reduction in bronchiectasis exacerbations. Why? What's going on? Well, one hypothesis clearly is that there really were fewer exacerbations. And I'm going to show you some data to support that that is actually true. But there was a more worrying hypothesis that actually had a lot of people very concerned. Not that there was a real reduction in exacerbations, but people were too scared to come to hospital for treatment. That those people were sitting at home or not able to access care, and therefore this reduction in hospitalizations was no such thing. Same number of events, just being treated inappropriately in this instance in the community. If that was true, though, you might expect to see two things. You might expect to see increased acuity or severity of those exacerbations which still got to hospital. And you might expect to see increased community treatment. You might also expect to see excess deaths in the community. And there's data to support that this is not what happened. Let me show you what I mean. This is a really nice study from Hong Kong, and like many others, it looked at the rate of COPD exacerbation admissions to hospital. But what I really like about this study is that it also looked at the rates of other admissions, including heart failure. And exacerbations of heart failure and COPD are not that different, really, are we? We're talking about a long-term condition and acute exacerbations associated with increased breathlessness. I can't really think of a reason why a person with heart failure would be more afraid to come to hospital than a person with COPD. That doesn't seem to make sense. So what we see here is that whilst there's a profound reduction in the number of admissions with COPD exacerbations through the pandemic, there was no reduction in the number of admissions with heart failure, suggesting that other emergency admissions weren't impacted in the same way that COPD was, suggesting there really was a difference in COPD exacerbations. Well, what about the community, and what about excess mortality? Well, we have some data on that as well. What we're looking on the left here is the pandemic year compared to a mean of other years, looking at excess mortality. Those graphs are the same. No suggestion in England and Wales of excess mortality in the pandemic year because of COPD exacerbations. And what you're looking on the right is primary care coded number of exacerbations treated by GPs and practice nurses. Blue, the long-term trend, red, the pandemic year. Profound reduction in community treated exacerbations too. Now, I accept that people might have had trouble accessing primary care during the pandemic, but nevertheless, it does support a real reduction in COPD exacerbations in the community and in hospital. Why? What's going on? Well, perhaps we need to think for a moment about the causes of COPD exacerbations. This is an old study, 20 years ago, but one of the first to describe respiratory viral infections as the most important cause of COPD exacerbations, and we now know that to be true. Single commonest cause, human rhinovirus. Note in passing that coronaviruses can also cause COPD exacerbations, or at least they could before they became famous for doing something else, but it's rhinovirus that's the main cause of a COPD exacerbation. If rhinoviruses and the reduction of transmission of rhinoviruses are the explanation for why there were fewer COPD exacerbations, then as well as seeing fewer COPD exacerbations, the proportion of exacerbations associated with the virus should also have decreased. And thanks to this group and this paper in Singapore, we now know that to be true. This is a similar plot. The blue bars represent the number of COPD exacerbation hospitalizations in this Singaporean cohort. The hatch bars at the bottom, they represent the proportion of those admissions where they could definitely identify a respiratory virus, not including COVID. And as well as seeing a profound reduction, we're used to seeing this now, that's what all the studies I've been sharing with you have shown, profound reduction, about 50%. There was almost complete absence of any viral-driven COPD exacerbations. So it seems that this reduction in exacerbation hospitalizations is being driven by a reduction in viral exacerbations. You know, that shouldn't really have been a surprise. This meta-analysis is 11 years old and was conducted in healthy people. It shows that simple low-cost interventions, hand washing, wearing a face covering, are effective at reducing the transmission of respiratory viruses in healthy people. And just look how prescient the authors' conclusions of this meta-analysis were, despite being written 10 years ago. They say, and I quote, "Routine long-term implementation of some of these measures might be difficult without the threat of an epidemic." Well, I think they got that absolutely spot on. There are some alternative mechanisms that may have contributed, and we should certainly consider. Air quality was better, at least for some people. Where I work and live in London, air quality was much better for a few weeks when traffic was reduced during the first lockdown. It's back to where it was before now, I have to say. And perhaps medication adherence may have been better as well during the pandemic. Maybe our patients with asthma and COPD and bronchiectasis were afraid of COVID. They took their treatment more reliably. So given what we know, indeed what we knew about respiratory viruses causing COPD exacerbations, and what we already knew about the ability of face coverings, of hand washing, to reduce the risk of COPD exacerbation admissions, it's quite interesting to look back with retrospect at what the GOLD, Global Initiative for Obstructive Lung Disease, COPD guidelines had to say about respiratory virus infection control measures. That's what they had to say. It's not a mistake on the slide. They had absolutely nothing to say about respiratory virus infection control measures. Same was true for the asthma guidelines as well. However, GOLD has updated, and to the credit of the GOLD Scientific Committee, they now include this statement. They say, shielding measures should be considered during the winter period in patients at risk of exacerbations. So the pandemic has directly led to a shift in the GOLD recommendations for COPD, and we're now encouraged to have conversations with our patients about what might be appropriate to them. That's all very well, but what are people living with lung disease? What are people with asthma, with COPD, with bronchiectasis prepared to accept? We'd like to share with you some data from a survey in the UK. Nearly 5,000 people took part in this survey, and it explicitly asks the question, not thinking about today, but thinking about the future, when we do reach this position of endemicity, thinking about the future after lockdown. What would you be prepared to do if you knew it would reduce the chances of picking up a respiratory virus and therefore an exacerbation? Well, let's start by looking at the data from asthma. Just over 3,600 asthmatics took part in this. On the y-axis, you can see the percentage who would agree to the particular measures that you can see along the x-axis. And I divided the patients in colour bars according to their age. Various interventions, so face coverings indoors, for example, on the left, indoor social distancing in the middle, avoiding sick family and friends on the right. You can see no clear consensus for many of these things. Some people would, some people wouldn't accept those measures longer term. In general, the older people were more willing to accept measures, apart from when it came to restricting their visiting to family and friends, where it was the reverse, where younger people tended to be more cautious. So it's clearly a very individual thing. Some people will accept, some people won't accept longer-term measures. Similar story for COPD. So the numbers are in the yellow bars. I haven't split them up by age because predictably they were all of a similar age. They tended to be older. But numbers not that different from our asthmatics. So most support for avoiding busy public spaces indoors and perhaps indoor social distancing. In passing, by the way, the other thing that came out of the survey, and I haven't put on the slide, is that patients were very keen for us, as healthcare professionals, to continue to wear face coverings outside the pandemic when we're seeing vulnerable people with asthma and COPD. And that certainly wasn't standard where I worked. I don't know if it's standard where you worked, but we're having to think about our practice. So it comes down to individual variation, and I suppose then as a healthcare professional, what we should be doing is having that conversation with the patient, saying, well, you could do this, you could do that. It's your decision. It's about risk and what you're prepared to accept in relation to constraint. But we should at least be having the conversation, and probably weren't before, and that's reflected in those change in GOLD guidelines. More generally, though, away from the effect on exacerbations, it's clear that the COVID pandemic had profound effects on the care of people with chronic respiratory disease. Services were, well, I've written disrupted, stopped in many instances, particularly thinking about spirometry. Evidence now emerging that that is not an aerosol-generating procedure in itself, but cough is. Also, pulmonary rehabilitation is something we should think about. And service disruption because there were no staff availability through their own sickness or shielding or redeployment. And you know that service disruption is ongoing because it's often respiratory staff who've taken on the challenge and the burden of dealing with long COVID too. And it's not just about the clinical care that was paused, but research and quality improvement was paused as well. Those of you listening to Mark Elliott earlier on will have heard him allude to the UK National COPD audit. And the effect on the audit is illustrated on the slide here. I should add that every hospital admission with COPD in the UK is supposed to be entered into the audit, and individual hospitals are under financial pressures to do two things. Patients are supposed to be seen within 24 hours of admission by a specialist. I don't mean a physician, it could be a physio, a nurse specialist, a pharmacist, but by a specialist in COPD. And prior to discharge, they're supposed to have a bundle of interventions called a discharge bundle, which thinks about smoking cessation, pulmonary rehab, follow-up and verification of inhaler choice and technique. And trusts have to have 60% of that to get all the money that they would otherwise be owed. And you can see after the audit went live in February 2017, right on the left of that slide, there was a gradual increase in performance as that financial incentive kicked in. But then a profound reduction in the early part of 2020 with the first wave, a less profound but definitely noticeable change with the second wave, despite 50% fewer cases, remember. But things have now picked up, and indeed performance is now back to where it was. COVID is important. Long COVID is important. But COPD is important too, and our patients need us, perhaps more now than they ever have. There's also been service innovation, more blended clinics, virtual clinics. But it has led to the question of which aspects of COPD care can and cannot be delivered remotely. There's quite a bit of work looking at this, but this is another UK survey, forgive me for that, attempting to work out whether clinicians and patients had the same perceptions of what worked or not. And it turned out that they didn't. I think that was a little bit unexpected. So everybody agreed that simple things like taking a history could be done, or maybe making a decision about whether someone should use a rescue pack. You could do that virtually. The clinicians thought that they could use virtual consultations really effectively for assessing inhaler technique, even for physiotherapy support around airway clearance. The patients didn't, by the way. And there was no consensus about some of the other things on there. More difficult things, clearly. Not just more difficult things because they're practical, like an exercise test, but more difficult things that might be more intimate, like advanced care planning. I'd like to end with a positive, actually, because I really do see some opportunities for future change. We've talked about air quality, and we've talked about this 50% exacerbation reduction. By the way, a 50% exacerbation reduction was beyond our wildest dreams. We're really happy in a big pharma study if there's a 15% reduction in COPD exacerbations. What I thought was impossible has become possible. How do we keep that? How do we leverage that? There's certainly been innovation in care, remote care, digital technology, and that is clearly the future. I'm going to hear a bit more about that later in the symposium, I know. And respiratory health in general, and the skills of respiratory healthcare professionals, you and I, are in the spotlight like never before. Having stood up together to manage COVID and to manage long COVID, I think we can be terrifically proud of what we've done and what we've done together. The question is, how do we keep that? How do we leverage that goodwill and good feeling? So in conclusion, 50% reduction in exacerbations beyond our wildest dreams in asthma, bronchiectasis and COPD, which appears to be real because of a reduction in respiratory virus transmission. There are therefore opportunities for individuals to continue to reduce their risk if we can find things that they're willing to do. And the pandemic did see innovation in respiratory care. So as our services rebuild and restart, let's keep the good bits of that innovation. Let's build on the goodwill, and let's continue to stand up together, not just to manage COPD, not just to manage COVID, but to manage airway diseases as well. Hope there was something of interest. Very grateful to AGIR for the invitation. Chairman, happy to answer some questions as well, of course. Thank you.
Thank you very much for the wonderful presentation. Really, thank you. Do we have questions or comments from the audience? I am really impressed by the range of decrease in the percentage of exacerbation. Could you compare this decrease to the classical interventions like bronchoinhaler or ventilators?
So that's such an important point, isn't it? You know, we were accepting of a 15% reduction, 20, 25% reduction with pharmacotherapy. Turns out that this and this, twice as effective. You know, there really is something that we can leverage there. But it comes down to individuals, and individuals will make their own decisions, I guess, about their own risk and what they're willing to accept.
I should say, if I am responsible for the health agencies, I would ask for a control group using face masks, for example, and washing hands in comparison to pharmacological therapies. It would be interesting, I think.
I think that's right. I mean, one of the things I didn't have time to touch on is how political, though, this has become. Certainly in the UK, certainly in the US. So finding a way through this is going to be dependent on the context that you're working in as well, I think.
Any other question? So just sorry, John, a question. There is a reduction in COPD exacerbation. On the other hand, some diagnoses could have been delayed during the. Do we have data on the consequence of this delay?
That's such an important point, isn't it? Because spirometry services, the primary way to diagnose COPD, were disrupted and remain disrupted. So for people who have an existing diagnosis, perhaps our more severe patients are the ones I've been talking about, but we also have to think about the likely hundreds of thousands of people who have had a delayed diagnosis and what the consequences of them. And that's the other side of this equation. The data to support that are not there numerically, but you make such an important point. I completely agree with you.
Thank you.
In some Asian countries, there is a cultural aspect of systematic use of facial mask. What's the difference in reduction in exacerbation, or do we have information? In the meta-analysis, I saw that in Germany there is less greater reduction. In Korea, it's quite the same than in UK or in France. Or
So we've recognized for some time from big pharma studies that exacerbation rates vary in surprising ways in different countries. I've never seen that specifically looked at in relation to the willingness of the inhabitants of that country to wear face masks, but that's a really interesting idea. And you're right, it's well established in some places. Whether that has translated to a reduction in older populations who perhaps aren't using public transport, I don't know, but it's an interesting idea.
Thank you. Thank you very much.
Merci. Thank you very much. Merci.
So now I think it's a good introduction after this good introduction by Dr. Hurst, I think the talk of Marik is very appropriate. Thank you, Marik. Is it possible to initiate a non-invasive ventilation at home? Thank you.
Yeah, thank you for the introduction. I hope you can hear me by now. Is it good? Yeah. As I'm still at home, and from this position, I would try to tell you today something about home initiation of non-invasive ventilation in patients with stable chronic respiratory failure. I'm from the University Hospital in Groningen, the Netherlands, and we are just recovering from COVID as we had quite high infection rates last week. So that's the reason why I'm still at home. A pity, but still I would like to show you these data. I hope it will continue. Like this, these are my conflicts of interest. So a bit of introduction to this topic. In the Netherlands, we saw that the number of patients on home mechanical ventilation has risen rapidly You see this in this graph, and we see this in actually all diagnoses. What we also see is that the number of patients with COPD increased last years. This was a challenge for us, and as these numbers are still rising, this challenge still exists. But what happened then? We were faced with increasing number of patients that needed or that were indicated for home mechanical ventilation, and then COVID came up, and we were also faced with a lot of COVID patients and no space anymore for patients that had an indication for chronic home ventilation. So what happened in the Netherlands? To give a bit of an overview, we were facing the COVID in the first period in February 2020, but we had a couple of rises again during the year and also during last winter. And all these rises limited the capacity of our hospital to take patients to be initiated on home ventilations. So actually, this stressed the importance of a method that we already investigated before the COVID started. And the fact is, we were questioning already longer before whether home initiation of non-invasive ventilation would be feasible, non-inferior compared to hospital initiation, and safe. I would like to discuss this with you, presenting the results of the studies that we did. And after that, I would like to talk a bit about what is necessary to make this the solution. So one of our nurses, Anne Hazenberg, already did a study almost 10 years ago, as she was asked by one of her patients whether the initiation of non-invasive ventilation could also be done at home. At that time period, we initiated all our patients in the hospital. We took them in the hospital and they stayed there for a couple of nights. But the patients recognized that this was not the way they wanted it. They wanted to be at home in their own environment. So these are the results of the study by Anne, and this study was performed in patients with neuromuscular disease and patients with restrictive thoracic disease. And Anne showed that initiating non-invasive ventilation at home was non-inferior compared to initiating in the hospital, as you see that the CO2 went down in both groups to the same amount. There was no difference in change between the groups. When we look at the ventilatory settings that were used in this study, we see that moderate inspiratory pressure was used, as we are used to use in patients with neuromuscular disease. This study was actually repeated in a multi-center national trial by Ries van de Bigelaar, and this was published in 2020. This was a study in which all the Dutch home mechanical ventilation centers, which are 4 in the Netherlands, participated. Again, neuromuscular disease patients and restrictive thoracic disease patients were included. And also, Van de Bigelaar showed that the reduction in CO2 was the same in both groups, and the difference in change was not different. When we look at the time needed to initiate patients at home compared to the time needed for the nurse to initiate patients in the hospital, we see that home initiation took more time of our nurses. And to be a bit more clear what we did, one of the nurses of the home mechanical ventilation center drove to the home of the patient. She explained it. She explained the ventilator, she explained the transcutaneous measurement device that we used, and then the patient started to use the NIF at home. And then she had a daily contact until the ventilation was satisfactorily settled. And what you see here that it took more time, and this was mainly due to traveling time because the nurses had to drive to the homes. And then the COPD patients. It was for a long period believed that home initiation wouldn't be possible in patients needing high intensity non-invasive ventilation. Actually, we know that in COPD patients, we need a bit higher pressures compared to the neuromuscular patients. This is one of the first high-intensity studies by Michael Dreyer, showing that compared to the pressures used before, we need higher, mainly inspiratory pressures to ventilate these patients properly. And when you look at this first study of Michael Dreyer, the inspiratory pressure and also the breathing frequency was very high. But we thought, okay, we are not really convinced that this would not work in COPD patients. So we started this trial, the Reconsider trial, in which we again investigated whether home initiation was non-inferior compared to in-hospital initiation of NIV, but in this case in COPD patients using high-intensity NIV. So this was our hypothesis: home initiation of NIV with the use of telemedicine in stable hypercapnic COPD is non-inferior to in-hospital NIV initiation. And we defined a difference in favor of the hospital group of smaller than 0.4 kPa in PaCO2 as non-inferior. So what we did, patients were randomized between in-hospital initiation and at-home initiation of NIV. And actually, this is a picture of one of our nurses with a patient participating in the study. The process was followed, as I already explained. When a patient was randomized to home initiation, the nurse drove to the home of a patient. She explained it, she practiced a bit with the patient, and the patient started to practice by himself at home, and she had daily contact and a daily readout of the telemonitor data. And then after 3 months and after 6 months, we saw the patients at the outpatient clinic and investigated our outcome parameters. What did we monitor? We used the ventilator in that period, still with a modem on the back of the ventilator, so that a daily readout of ventilator parameters could be done. And we also used the transcutaneous monitor to check for gas exchange. And during that time period, it was not possible to have directly remote transcutaneous data, so we had to use an in-between device which sent the data over the internet, so we could also have readouts of the transcutaneous monitored gas exchange data. We did not do a gas exchange check every night. We did it in the beginning to have a baseline value, and after the patient was sleeping quite well with the ventilator. So in this study, we did a median of 3 gas exchange measurement per patient during the initiation period. So this is the study flow. I'll go back. We randomized 67 patients between at home and in hospital initiation. Some patients dropped out, as could be expected in this severe group, and we analyzed 23 and 26 patients. So what were these patients for kind of patients? It were typically COPD patients using long-term oxygen therapy in 80% of the cases. They had a BMI of 25. We also tested for sleep apnea. The number of patients who had concomitant sleep apnea was very low, and the same in both groups. And also patients were offered to do a rehabilitation program after they were initiated on NIV, as this is main policy in our country, as we are convinced that combining NIV with a rehab program is very effective for this group. And we saw that this was used in a part of the patients. The same in both groups again. So this is the primary outcome: daytime CO2 at rest without oxygen, without ventilator. And here you see the group that was initiated at home and the group that was initiated in the hospital. And you see that the reduction in both groups was the same. And the difference in reduction was also very low, 0.04. And also the confidence interval of this difference was within the 0.4 kPa, which we defined in the beginning as a non-inferiority margin. Here it is. So we also checked for lung function, 6-minute walking test, lung function walking test. And again, the difference in change between both groups was very low, and also the confidence intervals were very low. So there were no real differences in change in outcome parameters between both groups. We also checked for quality of life with the CCQ, a COPD questionnaire, and the SRI questionnaire developed for patients who are hyperventilating. And as we see here, both groups had a change in quality of life. There was again no difference in change between the groups. When we look at the ventilatory settings that we used, comparing it to the neuromuscular patients, we see that we indeed used higher settings, higher inspiratory pressure around 20 to 25 centimeters of water, and the breathing frequency somewhere between 12 and 15 breaths per minute. What is quite obvious here that we used a bit higher pressures and also a bit higher breathing frequency in the patients who were initiated in the hospital. And what we also can see here that we tended to increase the inspiratory pressure a bit more in the patients that were initiated at home during the follow-up period. However, this did not lead to differences in outcome. We also looked at the costs of initiating patients in the hospital compared to the home situation. And there you have to keep in mind that we were used to take patients in the hospital, having them on the pulmonary ward for around 5 to 7 days to be initiated on NIV. And if you compare this strategy with the strategy we used for home initiation, we see that the costs were much lower, as we did not have the cost for the ward days that we normally had. So we showed in this study that also in COPD patients, home initiation of chronic NIV was non-inferior compared to in-hospital initiation, was safe and reduced the costs. We did use a system of telemedicine using ventilator data, but also gas exchange data. And finding this had important implications for both our patients and the healthcare system. And this was even before the COVID pandemic. And you can imagine that now, when the COVID pandemic appeared, this became even more important. So, is remote NIV setup feasible, non-inferior, and safe? I think we can conclude yes. And then we came with the issue, what is necessary to make it the solution? And this is not that easy, I need to say. We are still busy with the process of implementing this in regular care. And you might enter up with issues. Is it a reasonable option for all our patients, or are there still patients for whom home initiation is too difficult or even impossible? Patients and caregivers should be digitally proficient. And actually, I need to say that even the older patients are having more and more smartphones, and they're using WhatsApp with their children. So this becomes more easy. However, it's not the case in every patient. So the techniques that we use should be easy to use. Quality should be at least the same or even better. And you should, what we did, we also monitored gas exchange at home to ensure that the quality was the same and that we titrated the ventilation in a good way. So this is with regard to ventilation, but also the way you monitor patients. And I think the discussion about what you should monitor is not closed yet. It needs a different organization of your team. I'll show you later about the time needed for our nurses to initiate patients at home. This might be a bit more, but we can also think about organizational things that can be more efficient. There are legal issues, security issues, reliability issues of the devices that you use that you should think about. And is it a reasonable options for all our patients? I got this graph from Ries van de Bigelaar. He checked in the National Multicenter study that he did whether this was an option for all patients. And what we see here, that there were reasons why patients did not participate in the study or could not participate in the study. Some patients came with an acute situation and then were initiated on NIV afterwards. There were also organizational issues for the centers why they could not initiate patients at home. There were patients that had an insufficient social network. Some patients declined to participate. We did not know whether this was because of the study or because of the home initiation, and he excluded children. And if we count this up, I think you can say that we can prevent the organizational issues and maybe also the issues with regard to the social network. Organizational issues can be solved by improving your organization, and maybe the social network can be improved by using healthcare providers from the community or a family that wants to help. So, adding this up, there will be 10 to 15% which probably needs initiation in the hospital. And then about the digital skills of the patients and the healthcare providers. Unfortunately, it's still the case that not on every place in the world there's a good internet connection. And even in the Netherlands, you cannot imagine, but there were places where patients were living where the Wi-Fi connection which we used at that point was too bad to have good telemonitoring. So to look at the organization of our team, in this graph, I combined the COPD study and the neuromuscular study and looked at the time needed for the nurse to initiate patients at home. And you see in both studies that initiating at home took our nurses more time compared to initiating patients in the hospital. And you can imagine how this works when a nurse needs to drive to one patient at a time, or she can take care of 4 patients lying next to each other in the hospital. This makes a big difference. And is it that easy? This was a graph from a poster that the nurse that actually did the COPD study presented on the ERS. And she looked at how many transcutaneous measures did work out at home and how many didn't. When we looked at the transcutaneous measurements performed in the COPD study, 73 were combined with telemonitored and 17 were downloaded at home as the nurse was at home at that time point. When we looked at the transcutaneous measurements that were intended to be sent to the hospital via telemonitoring, we see that there were 31 problematic measurements showing no graphics, no sufficient Wi-Fi connection. One patient forgot to connect the device to the telemonitoring system. One patient forgot his NIF, and 25 patients had no CO2 monitored. So it was not that easy, and this resulted in additional home visits for the nurse, and so also additional travel times, or even not sufficient transcutaneous measurement. So it was not that easy, and I think this points out that the techniques can be improved, and this will make the process of home initiation more efficient. So this is a graph which you might know as Jean-Christian Borel made this. I always like this very much, showing the progression of the way we monitor patients eventually on NIV, and the way we now can monitor patients remotely on NIV devices at home. And when I compare this to our situation in the Netherlands, one of the first studies we performed comparing non-invasive ventilation and rehabilitation to rehabilitation alone in COPD, then NIV at that time point, and that was 2004, was initiated in the intensive care unit in our hospital, and patients all had a radial artery line to draw blood samples and to titrate the NIV. And then we stepped down to the respiratory care unit on our normal respiratory ward, and now we step down to the home situation. And what do we need when we initiate patients on NIV? I think this is a really nice discussion, because you can monitor almost everything, but the question is, what do we need to monitor? And I know that Maxime Patou showed us very nicely a couple of years ago in a pilot study that nurse-led titration of NIV using the nurse and the transcutaneous monitor was as good as very sophisticated PSG titration of NIV, and the CO2 went down even more in the nurse-led group compared to the PSG group. So do we need monitoring? What do we need to monitor? Or can we even let the ventilator do the work? And I know there's a trial from London, but I think it's not published yet, which looked at automatic mode of titration of non-invasive ventilation in patients with obesity hypoventilation. So we are very curious what the outcomes are. So to combine this, what can we monitor? What do we need to monitor during the initiation phase and during follow-up of our patient? We don't know yet. And I think it's good to remember that when we want to monitor at home, it should be easy and it should work. What we did in our initiation studies, we monitored ventilator data and gas exchange, but I showed you that gas exchange measurements were not that easy in every patient. We can monitor a lot more, like PSG's work of breathing, patient ventilator asynchrony, but the value of this kind of monitor will need to be proven first. So my take-home messages: home NIV setup with ventilator data and CO2 monitoring is non-inferior to in-hospital setup. It's feasible and safe, both in neuromuscular disease and COPD. However, there are challenges for implementation in regular care, both concerning techniques at home and organization. There's an ongoing discussion about parameters that should be and can be monitored remotely to adjust the ventilator optimally, both during initiation and follow-up. So this was my talk. I'd like to thank all my colleagues. We're a big team, and this is our hospital by night, and I'm happy to answer your questions.
Thank you, Marik, for this very comprehensive talk. Is there any questions? Yeah.
Thank you very much. Sonia Kirani from Paris. My question, if I'm not wrong, does it mean that you never control the breath-by-breath data of built-in ventilator, built-in software ventilator during the initiation and follow-up of the patients?
No, that's not correct, as we download the ventilator data also during the initiation process, and we can also check for breath-by-breath data.
Okay, thank you.
It's a bit dark for me, I think, now. I can put the light on, but if there are no more questions, I just shut my video.
Marike, I think we are a little bit late, so we should move on to the next talk. Thank you very much, and congratulations for the great data and the great contribution to the Congress. It's time now to move on to the next speaker, Dr. Alessandro Onifri. I hope my pronunciation is correct in Italian. He's going to talk, he's from Roma. He's going to talk to the telemedicine and remote monitoring solution during COVID-19 in patients with chronic respiratory failure on long-term ventilation.
So, thank you very much. I'm Alessandro Onofri, and I work in the pediatric pulmonology of Bambino Gesù Children's Hospital in Rome. My talk is about telemedicine and remote monitoring in patients with respiratory failure during the COVID-19 pandemic. Let's start with some definitions very quickly. Telemedicine is the remote diagnosis and treatment of patients by using telecommunications technology, and telemonitoring, which is the use of information technology to monitor patients at distance. When we will speak of telemonitoring during this talk, we will speak about ventilator telemonitoring. You know that data from ventilator, from built-in software ventilator, could be downloaded with SD card, USB, Wi-Fi, Bluetooth, And now, recently, we can use web access platforms to download ventilator data. So the ventilator transmits to the cloud platform once or more times a day, and the physician can analyze ventilator data from the dedicated web platforms. We have in this table some nice examples of web access platform for NIV telemonitoring. Another definition which is very important for this talk, I work in a pediatric unit, so it's very important to talk about children we deal with. We deal with children with medical complexities. These children are children with one or more complex chronic conditions. They have chronic respiratory failure, but they have often multisystemic and severe comorbidities. They are children with functional limitations, so are often dependent on technologies. They are high users of healthcare resources. They have frequent hospitalizations, they require often outpatient visits and so on. And they have high needs at home. So before pandemic, the telemedicine was perceived by families with children with chronic conditions, as we can see in this very nice paper, which explained that families are well predisposed to telemedicine, even in the case of children with complex chronic problems. The pediatric context also is favorable because we work with young families, so they have great familiarity with technology and so on. And obviously, telemedicine system in 2019, when this paper was published, required implementation with adequate infrastructures and trained staff. More recently, this randomized clinical trial compared the standard of care with telemedicine and the standard of care alone for children with medical complexity. So it's a quite huge trial with 422 medically complex children divided in two groups, and the authors found that the probability of reduction for care days outside the home, serious illness, and mean total health system costs were higher for the use of telemedicine with standard of care compared to the standard of care alone. So telemedicine seems to be worth for children with medical complexities. Obviously, you know, and we spoke about it in the present talks. The COVID-19 changed the healthcare system and so changed the life of families with children with medical complexity. This Italian experience in this paper reported that about 60% of children missed at least part of the planned medical checks during lockdown period. During the lockdown and also after the lockdown, most patients received less support from nurses at home and a reduction in physiotherapy activity. So in conclusion, families experienced a reduction in perceived support. On the other side, we can see that the work changed also for primary pediatricians. Before lockdown, they worked with in-person visits. During the lockdown, in-person visits were reduced dramatically and then increased again. But when we speak about phone visits and other forms of telemedicine, you can see that with the lockdown, progressively, you can see an increase in phone visits and the use of telemedicine, also after the end of the lockdown period. So this very nice editorial on New England Journal of Medicine on March 2020 titled that maybe telemedicine could be perfect for COVID-19 because COVID-19 pandemic necessitated a rapid development of telemedicine systems due to the need to reduce in-person visits. The use of telemedicine makes possible not to expose the patient and clinical staff to the risk of contagion, and COVID hospital and COVID intensive care units can use telemedicine for their units. This is our little experience with telemedicine. I want to start with our numbers. We follow up children with medical complexity on long-term ventilation, and you can see that we have a strong, a great number of children followed up in the center and in the south of our country, of Italy. We follow up children mainly with neuromuscular disorders, with central nervous system disorders, and with upper airway disorders. During the lockdown period, we started with a telemedicine activity due to the necessity to postpone admissions and follow-up visits for our patients. So at the moment, we have 43 patients, 25 patients on televisit and telemonitoring, and 18 patients only on televisit. These numbers seem small, and actually are small, but this chart explains why we have so small numbers. Our region is Lazio, where Rome is, and our patients are mainly from our region because the refound system in Italy for telemedicine activity is not active. So we have refound only for patients of our region for activity of telemedicine. We mainly follow up patients on NIV, but also on invasive mechanical ventilation, so tracheostomized patients and so on. And we have patients mainly with more than 12 years old. I want just to let you know how we structure our televisit. We start from the clinical conditions of the patient. We assess eventual exacerbations, exams performed at home, eventual changes in the therapeutic plan. Then we evaluate the patient and vital signs, SpO2, heart rate, and so on. And then we go through the home care, and we want to deep the information on home care, especially during the lockdown period. As we said before, during the lockdown period, families received less support at home, so we assessed from our hospital if there are discontinuity of provision of services at home and eventual changes and so on. Then we go to the ventilator therapy. We ask to the family if they have problems with ventilator therapy. If they have any problem, we have our specialized nurses to explain and to help family with the ventilator, if possible. We asked about technical assistance to the ventilator if it was provided normally, especially during the lockdown period. It was a problem in Italy. And if the consumable continue to be supplied regularly. We try to plan our visits as far as possible in the presence of a physiotherapist and or a nurse and primary care pediatrician at home of the patient with our specialized nurses and physiotherapists. Then we go to ventilator data. We mainly focused our attention on the utilization of the ventilator, so hours of use, day of use. Then we go to the curves. We actually use 1 month of observation, but we go also to the last night ventilation just to have a look at the detail, at ventilatory details. So we go to tidal volumes, minute ventilation, leaks, the effective patient-ventilator interaction, and synchrony. We go to eventual respiratory events when available, this data. And when feasible, we go to combine ventilation curves plus pulse oximetry and, if possible, transcutaneous or end-tidal carbon dioxide. This is an example. This is a summary of our patients on telemonitoring with a web access platform. We have a very quick access to daily hours of use, leaks, and AHI. This is another example of how we can combine flows, curves, volumes, leaks, and in this case we have also the data of transcutaneous carbon dioxide. And in this table we have the statistics of a period that we have selected before. This is a clinical case, just to let you understand our activity. We are in Rome, so we have a third level hospital, and we have a 3-year-old female with mitochondrial encephalopathy who lives in Sardinia, which is quite far from our center. She's on NIV during the sleep, enteral feeding. She has an home assistance with nurse and physiotherapist. And family asked us for an extra televisit due to a respiratory exacerbation during the lockdown period. The child was experiencing fever, desaturations, increased secretions, and the need for oxygen supplementation. This was the monitor of the ventilator data. You can see that during this period, the child was increasing the daily use of ventilator, and she was using not only during the night, but also during the day, and that she was having an increase of AHI during this period, which was the period of the exacerbation. We tried to manage the exacerbation remotely with daily televisits, with daily telemonitoring of ventilator data until clinical improvement, and we had 2 online meetings with primary care pediatrician, nurse, and physiotherapist of the patient. The result was a prescription of more cough machine sessions at home with the physiotherapist, with the home physiotherapist, an increased therapy with aerosol, sputum analysis. She started antibiotic, and we changed ventilator parameters, increasing pressures and backup rate, very slow and very small changes, but we made with the primary care pediatrician at home. This was a small work that we published on pediatric pulmonology, and is on 21 patients on long-term ventilation with NIV or with NIV or invasive mechanical ventilation during the lockdown on 2020, and we divided 2 groups. One group was with televisit and telemonitoring, and the other group was with televisit without telemonitoring. You can see that in the group with telemonitoring, we found more ventilation problems, and in 4 cases out of 5, we changed ventilation parameters. I'm speaking of very small changes, but they were good, and patients improve in all the cases. This is another study, a pilot study published after pandemic, that showed the utility of remote monitoring to evaluate the adherence in the use of the ventilator after starting NIV. Authors found that remote monitoring improves adherence in children in the first months after starting the NIV, and that remote monitoring allow an early interception of any problems with ventilation, and the remote monitoring was well perceived by caregivers. So this slide, I think that is very important because each point could be a topic. There are few open questions, maybe there are more than this, but I think that the problem of digital divide, as Dr. Duerman said before, is a very big problem, and we experienced this in our country because there are some people far from our hospital without a good internet connection, and we cannot perform televisit to these people. Technology requirements is strictly linked to digital divide. Maybe as many people cannot have the technology requirements to perform a good televisit or telemonitoring. The problem of costs and refund. I presented our case before. We have not a refund for telemedicine for people out of our region. A more philosophical point is the changes in patient and doctor relationship. And two practical points are privacy and data security, which is very actual, and the lack of specific laws for telemedicine. Future directions for telemedicine are obviously, as I said before, to increase inclusiveness and accessibility for everyone. The use of artificial intelligence to improve home health assistance, the improvement of health data management. Is important to develop specific laws on telemedicine and to have more cost-benefit analysis to develop a sustainable reimbursement system for telemedicine activity. Thank you very much for your attention.
Thank you very much. Again, we are late. Do we have some burning questions from the audience? Do you really think that we are ready for artificial intelligence management of the telemonitoring of non-invasive ventilation, or should we wait a little bit?
I think that is quite early for this, but maybe is an interesting direction for telemedicine. I think that we are not ready for it. Maybe in Italy, I don't know in other countries, but...
Sonia?
Yes, Sonia, please.
Thank you. Thank you, Alessandro. Did you have to change some NIV device in some of your patients because you could not have access to remote data on the platform because it's a tricky point in pediatrics?
Yes, sometimes we had to change ventilator. Yes, because we don't have telemonitoring for some patients, and when required, we had to change. Yes.
Okay, so thank you very much.
Thank you.
We are a little late, so thank you, Laurent, for the last presentation on the feasibility of hominization of airway clearance device by telecare. Thank you.
So thank you for the great invitation, and I will be very short. I know that most of you have been invited to a very famous restaurant in the downtown, and I lost 50% of my time. So, okay. So I have the great pleasure to present the main results of the home care bronchiectasis trial. And I would like to thank warmly all the patients, the investigators and their team, and ICADOM team for the great work, the great job they have done during the conduct of this trial. So the goal of this trial is to evaluate the feasibility to implement a new technology for airway clearance at home, combined to telecare. And I will present the results after 3 months of Symiox therapy in a cohort of patients with non-cystic fibrosis bronchiectasis who have some difficulties to access to usual chest physiotherapy. And you know that especially during the lockdown, it was a great challenge for patients to visit their chest physiotherapist. Most of the private practice offices were closed. Hospital, there was no access to hospital, so it was a big issue for the patients. So here are my conflict of interest, not significant. So you know that in patients with chronic respiratory disease, and especially with chronic mucus hypersecretions, the overproduction of mucus and mucus stasis are a key component through a cycle vicious to lead to a decline of lung function and pulmonary exacerbation. So it's very important to provide the patient with very efficient solutions to clear mucus in their airways. So the last airways guidelines recommend regular airway clearance in patients with bronchiectasis, especially in patients hypersecretant. And in case of excessive secretions, it's recommended to clear airways every day and even several times a day. So we, in the situation of COVID pandemic, there was clearly a great limitation, and other limitations are also the availabilities of chest physiotherapy in patients aware, and also the schedule of patients and availabilities of professionals. So Symiox technology, it's an innovative airway clearance device that generates a highly precise signal that disseminates in the lungs. And the goal of these mechanical vibrations are to act directly on the rheological properties of mucus, to liquefy secretions, and to mobilize also the secretions by a suction mechanisms from the distal airway to proximal airways to be naturally expectorated by the patients. So this device can be used with the assistance of respiratory therapists, but also in autonomy at home. So the next slide. Okay. Yeah. So the assumptions of the trial were the following. So Symiox at home can be innovative solutions for airway clearance for these patients. And combined with telecare, we will be able to train remotely these patients to the use of the device in autonomy, and also to schedule regular follow-up of Symiox therapy with motivational reinforcement for its use. So the overall purpose was to conduct a pilot clinical trial that will assess the feasibility to train remotely patients with the device, and also to collect data for designing a future well-powered RCT in this population. So there are the three investigating centers. So we included 22 patients with bronchiectasis and chronic mucus hypersecretion. And we first, we evaluate the use of Simiox at home after 3 months of therapy. And we assess also the feasibility of telecare performed by a respiratory physiotherapist, expert of the device, for the training, the setting up of therapy, but also for regular follow-up every 10 days. So inclusion criteria was objective diagnosis of bronchiectasis confirmed by high-resolution CT scan with overproduction of mucus and unstable disease, and we exclude risk factor, significant risk factor for chest physiotherapy. So the primary outcome was the percentage of patients who perform at least 3 sessions of airway clearance with Simiox per week after the training period of 2 weeks. The compliance data were collected on a jury card or transferred directly on a specific server with a tablet connected to the device in Bluetooth. So we had several secondary outcomes. I will not describe everything now, but we evaluate the use of the device over time, the patient satisfaction with the use of the combined solution Simiox and telecare. We try to identify factors correlated to the adherence, and also the feasibility to perform sputum collection once a week by the patients. For clinical data, we used several questionnaires of life, quality of life questionnaires, spirometry, and of course, we collect every side effect during the study. So this is a flowchart of the study. So in ITT analysis, we analyzed 22 patients, and we have excluded 1 patient from the ITT analysis because of a differential diagnostic. After the study, patients had cystic fibrosis. So I will present the results of per protocol analysis in 21 patients. So it was mainly middle-aged women with a low BMI and with mild to moderate lung obstruction, with a severe disease, and usual comorbidities that we find in this population: asthma, COPD, and chronic sinusitis. So a patient was adherent if he used the Simiox device at least 3 times per week. And so adherence was 65% in the study when we consider the self-report compliance completed by the patients on the jury card. But if we add the data transfer on the web automatically, this level reach 81% of patients adherent with Simiox solution. Jury and web data was very well correlated. Compliance for Simiox solution was very stable over the 10 weeks on follow-up, with a median range between 3 and 5 sessions per week. And we were not able to identify any factor correlated to adherence, probably because of the low sample size. We had only 4 non-adherent patients in the study. This study confirmed also in practice the feasibility for patients to collect a sputum sample every week. You can see that the medium sputum weight remains stable over time, but we had a reduction of data variability at the end of the study, showing a decrease in the EVS sputum samples. So, suggesting that patients with high volume of sputum decrease the quantity of sputum at the end of the study. We had a very high satisfaction level for the solution Simiox combined to telecare. And but it's not only because we create again social interaction between middle-aged women and very nice chest physiotherapist in video conference, but also probably because the device was comfortable and efficient for these patients. So we didn't find any change in spirometry in this population. And regarding the quality of life questionnaires, we had a significant improvement in several domains of the QL-B questionnaires, very specific to bronchiectasis patients, and especially for vitality and treatment burden score. And we had also a positive trend in health perception and social functioning that are very close to the statistical significance. Regarding the St. George respiratory questionnaires, once again, the total score improved by more than 4 units, so above the minimal clinical important difference. And each of the 3 domains, symptoms, activity limitation, and psychosocial impact, improved also above the MCID. LCQ show very similar results. The results were very close to statistical significance, but improved also above the MCID for each domain. And the CAT score that has been recently validated in patients with bronchiectasis improved significantly by more than 4 units. And so it's a significant improvement for each domains of cough expectoration especially. Regarding the safety, 4 patients were hospitalized for pulmonary exacerbation during the follow-up, but only 1 patient stopped definitively Simiox therapy at home due to exacerbation. We had very few side effects, possibly related to Simiox. No serious side effects. 3 patients had a worsening of chest pain, especially during expectoration. 4 had some worsening bleeding in sputum, and 1 had worsening GERD symptoms after 9 weeks of device therapy. But the side effects were not severe, occasional, and all of them resolved rapidly, except the patients with GERD symptoms. Despite the side effects, we have no permanent discontinuation of Simiox therapy. Only 1 patient stopped temporarily during 48 hours. So in conclusion, patients with non-cystic fibrosis, bronchiectasis, with chronic mucus hypersecretion have a high level of midterm compliance with the combined solution Simiox and telecare, and a very high satisfaction for its use. Both remote training in Simiox use and therapeutic follow-up by telecare are therefore feasible. That's the conclusion of the feasibility study. And the results suggest also that Simiox therapy is safe and efficient to improve airway clearance and, as a result, symptoms and quality of life. Of course, the clinical effectiveness of this procedure must be evaluated in a well-powered randomized controlled trial in this population. Thank you very much for your attention.
Thank you very much, Laurent. Do we have questions in the room? So what are the next steps after these fascinating results?
We have amazing data, especially on quality of life, and the next step is to design now a very well-powered RCT in this population, where clearly the target population for this technology, patients with bronchiectasis and mucus and chronic mucus hypersecretions. And there is also high expectations from this population to get very efficient airway clearance therapy. So that's the next step to design this multi-center trial.
Discussing with Jean-Christian, I think the very original topic is this patient without any access to care with good physiotherapists. It's one point. And the second question, what is the total population of this patient with non-cystic fibrosis bronchiectasis? I am unclear with the size of the population.
You are talking about the prevalence?
Yeah.
Yeah, effectively, it's quite difficult because these patients have a lot of respiratory comorbidities, asthma, and COPD. But we estimate in France probably roughly 40,000 patients with bronchiectasis in France. Yeah.
So it's a significant and huge population. Okay, if we have no additional... you have a question, John? Sorry.
Thank you for showing the data. I just was going to ask you what you think is the right control therapy for these kind of trials. That's tricky, I think.
It's a great question. Effectively, because it depends of the practice, the routine practice in countries, and there are some significant differences. But probably the gold standard in these patients is mucolytics, surely. And for airway clearance, conventional chest physiotherapy, at least. Perhaps it depends of countries, but some countries use, for example, PEP device. That can be also something to be considered for the group control group. Yeah.
Is it feasible to have a sham device, or do you think it's ethical and feasible to have a sham device?
No, it's also a good question. The problem is to replicate a sham signal in this device, and probably it will be very complicated to convince the patients to use the device who have the same problems with CPAP or NIV. Yeah.
Yeah, so thank you very much. I think we have very insightful talks during this session, and I would like to thank AGIR, home care provider, with a large audience in different regions in France. So thank you very much to the organizer and for staying here until 7 p.m. And now, as you said, it's time to go to the restaurant.
and thank you to the orators.